Next, I would like to call Dr. Abhishek Chandra. Please come, and your talk is regarding my experience with Schwind Amaris.
So very good afternoon to all of you in the post-lunch session. Good afternoon, Dr. Mazhari. Thank you for inviting me for this workshop with the CARE group. So I'd just like to give a brief overview of my early experience with Schwind Amaris. I have been using this platform for the last 6 months now, and I'm quite happy with this. So just to give a brief outline, what is a conventional LASIK? In conventional LASIK, we first give 2 marks usually by junction wallet stain. Then we apply a suction ring. A flap is created by a microkeratome, and the flap is lifted. And then we put the excimer laser, and then we reposit the flap back. So that is a normal LASIK what we are doing. In PRK, what we do is we remove the epithelium either manually or with the help of alcohol, and then we apply the LASIK. So what is transepithelial PRK? Basically, it's a misnomer because actually it's not going through the epithelium. Basically, we are removing the epithelium also and the anterior part of the stroma with the same laser. It may have a different wavelength or it may have a different setting, but it is the same laser which removes both the epithelium and the anterior stroma. So what we do in transepithelial PRK is that we focus the cornea and then we just press our foot pedal. So the laser first removes the epithelium, and with a different wavelength and a different tone, it removes the anterior stroma of the cornea. Then the cornea is washed thoroughly. We apply mitomycin C depending upon the power of the refractive error, and then we place a bandage contact lens, and the surgery is over. So let me tell you that transepithelial PRK is the most easiest surgery in ophthalmology. You don't have to do anything. You just have to focus, put your foot switch, do the laser, apply mitomycin C, and put a BCL. So it's one of the easiest surgery in ophthalmology and very rewarding surgery. So as I told you, the excimer layer removes the top layer of the cornea epithelium and the stroma in one step, and it reshapes the corneal tissue below and corrects the refractive error. So the central epithelial thickness is usually 50 to 55 micron. So with the epithelial mapping, you can exactly measure the epithelial thickness and you can remove the epithelium. The peripheral epithelial thickness at 8 mm is slightly more, that is around 65 microns. So it is on the Schwind platform that you can remove the amount of epithelium and stroma depending upon the thickness of the epithelium. And everything, both the epithelium removal and the stroma, is in one go. So you don't have to do it twice as in other machines. So this is just a cam profile of PRK and trans PRK in myopia, where you can see in trans PRK it is much smoother in trans PRK. This is in hyperopia. So this is just a video. I think it's not working. They just copied it. It shows that is a very simple procedure. You just need to focus it and do the epithelial removal along with the stromal removal. So now coming to the main thing, what is all about LASIK? Any surgery, the surgery is usually not difficult, but the complications to be managed is the most important thing for any surgery. So if you see the complications of conventional surgery, usually most of the complications are related to the flaps. So if you take the complications of microkeratome related flaps, it can have a flat buttonhole, it can have a free flap, it can have an incomplete, short or irregular flaps, then there can be wrinkling of the flaps, there can be a corneal perforation, and even if it's femtosecond, there can be a vertical gas breakthrough, anterior chamber gas bubbles, rainbow glare, other things. So coming to the post-operative complications, there can be an overcorrection or undercorrection that can happen with any LASIK machine. There can be visual rehabilitation. But most important, there are a few things which we more likely see in cases of a microkeratome-assisted flaps. That is, you can have a flap fold or stria. That is known as microstria. You can have a flap dislocation post-operatively. You can have a very severe dry eye, especially if you have not taken care in the early period. You can have a DLK or diffuse lamellar keratitis. There can be a pressure-induced stromal keratitis, central toxic keratitis, infectious keratitis. Then one of the very important thing is epithelial ingrowth, which I have seen in many patients, that after some time the epithelium grows inside the flaps, and then you have to either reposit the flap and clean it over, or you have to just wash it and sometimes it recurs again. There can be ectasia, and then there can be very rare complications such as retinal detachment. So one is, if you have missed the holes or tears in the periphery preoperatively, then you are more prone for that. And second thing, what happens when you are using a microkeratome, you for making the cornea tight, you have to increase the pressure very high, and then you suddenly decompress it. So sometimes what happens, due to this increase in the pressure and decrease, sometimes there is a PVD induction and then can lead to a hole. Sometimes in very rare conditions, it has been reported that this procedure has led to CRAO and CRVO with complete loss of vision. So I would say that LASIK is a very, very safe surgery, but still there are some amount of complications usually associated with microkeratome. Now coming to problems with transepithelial PRK, intraoperatively usually there are no other complications except that you have to focus it well, feed the power nicely, otherwise you can land up in a mess. Then immediate post-operative, there are two major problems with transepithelial PRK. One is the wow factor which you get in LASIK. You may not get immediate wow factor because for 2 to 3 days the patient is having a BCL and there can be a slight pain or redness, and for the second and third day there can be a slight blurring of vision by the time that there is epithelialization of the cornea. Then there can be watering, decrease in vision on the second and third day, and usually by day 7 or day 6 the cornea is fine, the epithelialization has taken place and the patient is very, very comfortable. Then the other complications are there can be overcorrection, undercorrection, visual aberrations. They can be dry eye, but it is usually less severe as compared to a LASIK because you have ablated less amount of the cornea and the depth is usually less with the same power. Then there can be a corneal haze, which is reported especially if you are not using mitomycin C. But with the newer LASIK techniques with the micropulse technology, the haze is less and the healing is better. And if you are using mitomycin C, in very, very few cases you are able to see the haze. Otherwise, there is absolutely no haze after the surgery. So then there can be infectious keratitis, but it is much less as compared to a LASIK surgery. Ectasia is usually less because the stromal residual bed is much more in comparison to LASIK, and the chances of retinal detachment is much less. So just to conclude, the advantages are it is much safer, easier surgery to perform, only one-step surgery, and it can be combined with aberration-free corneal wavefront or contura or ocular wavefront, and it can be combined with Presbymax, which is for presbyopic correction, and no alcohol is required. So there is disadvantages which I told you was no wow effect initially, but usually in around 80% of the patients do not complain because once you put a bandage contact lens, usually the pain and other things do not happen. In very few patients this does happen, and then you have to counsel the patient. And in very few patients, it's very difficult to predict, but there has been reports of mild subepithelial haze, which is there with any kind of PRK, but usually this is very less. And in the initial period, there can be a pain, discomfort, and watering in some patients. So just to summarize the advantages of Schwind Amaris, it is a quick lasering with short treatment times, sophisticated eye tracking for safe and precise treatment. It has the fastest eye tracking system so as to get better results. It has smaller laser spots as compared to other machines with smoother interface and ablated epithelial margin for faster epithelialization. For example, once you do a PRK, the epithelialization will take a little long as compared to the transepithelial PRK because the area is short and there is a smooth area, so that the epithelialization from the normal cornea to the deepithelialized cornea is faster. And there is a more gentle tissue removal through thermal control in Schwind Amaris. So this is smart pulse technology, which ensures it enhances the short-term outcomes or the wow effect. It reduces the residual roughness, which is the most important feature. It improves the smoothness of the residual bed, and without compromising stability or long-term outcomes, including aberrations in the refractive patients. So this is an electron microscopy. On the right-hand side, you can see that the surface is smoother as compared to a conventional laser. This is the clinical outcomes. So just to summarize our experience in the last 100 eyes, so 98% of the eyes have achieved 20/20 vision. In 92%, there was uncorrected 20/20 vision, but all eyes achieved, it is 20/30 vision at the end of 1 month. There was a minimal subepithelial haze was seen in 2 patients, but that did not affect the visual acuity. 3 patients had severe pain for the first 3 days, and then it subsided. And there's one thing which I wanted to have the opinion of the audience. In my study, what I found that 36% of the patients had a high IOP in the initial period, more than 30 or even more than 40, which is usually the steroid responders are usually 10%, 8 to 10%. But in my study, I found that it was really high, maybe because the epithelium is not there and there is an increase in the drug penetration of Predfort. I'm using Predfort. Many people use Elpred. But in this study, what I found that the pressure was relatively higher. But with medications, everybody was controlled, and after 1 month, we had to discontinue the anti-glaucoma medication. So to conclude, transepithelial PRK is safer, easier, faster, with low complication rate. And this is my hospital where we are working, and we are organizing the annual Eye Bank Station of India meet on 30th September and 1st of October. So those who want to come, you are most welcome for the meeting. Thank you very much.
There is a definitive advantage of trans PRK over PRK is that it is a single step process.
Yeah.
But I prefer PRK over trans PRK because epithelial thickness is not uniform. And if you are keeping the epithelial thickness 60 micron, and you will see the all epithelial map, you will see it is going from 52 to 62 kind of thing. So if you are applying the uniform laser, just removing the 60 micron, there may be surprise of.
No, sir. So in this case, what do? You first do an epithelial mapping.
Yes.
So you know exactly what is the epithelial light. And with the Cirrus 2, this information goes directly into the laser machine. So it removes exactly what is the epithelium thickness, so that there is no discrepancy between the epithelial thickness and what you are removing. So in that way, it is not a major problem.
Number 2 is the haze, post-op haze.
Yeah.
Haze is mainly because the post-op tapering of steroid is if you are very fast, not adding cycloimmune,
Yeah.
and lubrication is not adequate. Mitomycins definitely give advantage over
Yes.
that. But the most important challenge is the post-op 2 to 3 months, how we manage your case.
So that is why most of the people are using Elpred, I think, in PRK, but I still use a Predfort only.
I first used dexamethasone for 4 weeks, then I shift to 1 month more for on Elpred. With cycloimmune.
Yeah. So I usually go with Predfort for the first month in a tapering dose, and I have not seen much of a epithelial haze.
I avoid first Predfort in the first week because sometimes because it is sticky, you have application of BCL, sometimes folded down. Patient
But
I go.
You can see the white dots, but actually it doesn't hurt the patient.
Yes, I know. Thank you, Dr.
So thank you very much, sir.